Thank you, Dr. Hahn. So jumping into it, we have an 86-year-old male patient. He presented to us with a 7.3 centimeter thoracic aortic aneurysm. He had pretty extensive medical history, which is listed here, but he was a big cardiac cripple with an EF of 30% and pretty severe COPD as well. Then he also had a history of vascular disease. He had an EVAR that was done in 2021. So looking at his preoperative imaging here, we can see the aneurysm start coming into view here, just distal to the subclavian, kind of punching out, and then we restore back to kind of like a normal lumen. Looking at in the sagittal plane here, you can also just see it from like another view. You can see how close it is on that subclavian. This is not the best view to show it, but we don't necessarily have room proximally to seal to even like really get away with a TBE given the diameter here, which is about like 37. So going to our options, our surgical options, we could do non-operative, which is what he'd been doing for the past 5 years, just because he was deemed a non-operative candidate, but that comes with a pretty heavy rupture risk. You have the open option, you have the endovascular option, and the hybrid option. Given his comorbidities and everything, he couldn't undergo the gold standard, which would be a full sternotomy and a total arch replacement. The hybrid case would still require extra anatomic bypasses. We kind of talked about carotid, subclavian bypasses, and so we ultimately elected to go with the complete endovascular approach. So, given the fact that we're going to attempt this without a sternotomy and everything, we have to obviously plan. He had a type 3 arch. We would need to land zone 0 given the proximity of his arch vessels and the diameter. We use Terra Recon. There's 3Mencio and other 3D post-processing software that can be used. But basically this helps with centerline. This helps with osteodiameter, angulation, distance between them, just so we can plan when we actually customize our graft. Again, we also need to check our vascular access. Here we would need quite a bit. Here we access the right brachial, the left common carotid, both of the femoral arteries, and then the femoral vein as well for placement of a pacemaker. So the graft itself, we elected to use the Cook Zenith Alpha system. It was a tapered 40 to 36, 217 in length for like the main body that we were going to custom or to modify, and then the distal aspect was going to be another Cook product, TX2 this time, tapered to extend into the thoracic aorta. We elected to do branches for the innominate and the subclavian, and then a fen, reinforced fen for the carotid. We found that in the arch, there's like some literature out of Japan and like ourselves anecdotally that we have better luck with branches in the arch, just given the extreme hyperdynamics in the arch, given the proximity to the heart. And the other thing too that we need to consider here, especially doing a PMEG, is when we need to reconstrain the device, we got to consider bulk. And then the last thing too is seeing where the ostia are in relation to each other. You might not have place to do branches for everything. Intraoperatively, we'll go through the imaging, but just kind of high level. The pacemaker was placed so that we could pace him up to 160 just before graft deployment to kind of facilitate better alignment of our branches and our fens. The graft was landed zone 0. We did it over a safari wire, which we had gone through the aortic valve and planted in the LV. And the bridging stents are listed here. We can kind of go through them, but you'll notice we used the Gore TBE side branch, given the diameter of the innominate, and then we had 2 landing biobonds with the VBX bridging stents, which I'll show you in just a second. So here, a little bit of imaging. The initial one shows our diagnostic angio, if you will, showing the placement of the positioning, of the 3 vessels. And then our second picture, and then also you can see we had gotten right brachial access, so you can see the Ansel sheath here parked in the proximal innominate, the retrograde carotid sheath parked in the proximal left common carotid. The second picture is just positioning of our graft before deployment. You can see here it's like zone 0 over that safari wire that's through the valve, and again those catheters that we talked about, catheters and sheets. So this was a deployment of the graft with cannulation of the innominate. That's this one right here. This was a Jaguar. We snared it through and through to facilitate passage of the Gore TBE side branch stent to come up right here. And this was the 12 to 20. It was about 20 right here distally, just to kind of help it go through the branch that we'd built for it. And then you can see here from the common carotid, we had dropped a wire through that sheath into the ascending aorta. And then here's our completion angio just for the innominate. You can see you have good wall apposition and no evidence of endoleak. Looking at turning our attention to the left common carotid here over that glide wire that we had parked in the ascending. We deployed a Vibon distally and then a VBX to bridge from the fen through it. We found that by doing that, it kind of decreases the incidence of dissection in those great vessels. And this last picture here showing us going after the subclavian. We put a 10 French 65 centimeter dry seal up into the arch, cannulated the subclavian with a glide wire advantage, and then delivered our Viabon and VBX across it. So next picture here just shows all of our stents, the innominate, the left common carotid, and the left subclavian, along with our distal sealing T-bar. This is the TX2 system again, and then here's our completion angiogram, which shows filling of all the great vessels, no evidence of any kind of endo leak, no dissection in any of the vessels, and good wall apposition of our stents. Post-operatively, the patient did really well. He was discharged on post-op day 4. He spent a couple days in the unit just so we could keep a close eye on him. And then we saw him at 1 month, saw him at 6 months, and we just actually saw him for his 1-year follow-up. He's doing very well. He has no complaints. His new imaging we'll go through here, but basically shows persistent.
That's it.
All right.
Time.